So what I'm going to do is entertain questions, and I'm going to have to ask that the I have to get the screen back up that allow me to look at questions. So there we go. Okay, so if you could please type your questions into the chat box, I can answer any questions that there might be.
Okay, great, Dr. Frank. Wow, you've covered a lot of information in your slides, so we'll give people a chance to type their questions in the chat box.
Ordinarily, when I speak...
Go ahead, sir.
No, I'm sorry. I was saying ordinarily when I speak to people in your typical setting in person, I always invite comments and I invite participation. I'm never really good at giving a didactic talk. I like that the participants are able to interject at any time, put their hands up, ask questions, and so on. This format didn't allow me to do so, so I do apologize if I rattle on for too long, but hopefully I can answer your questions.
Mm-hmm. Yes, it's just a limitation of this technology, but we appreciate that you want to be engaging. Just so you know, I'll just quickly run through the type of folks that we have online. Some people did give us a bit of a snippet of where they're from and what they're doing. We have a recovery support worker joining us, a couple of people within the regulation field, a primary care RPN with very little knowledge in the addictions area, but obviously wanting to learn more. We have Kristen from Scotland joining us today. Welcome. She's head of the National Naloxone program in Scotland and obviously very aware, and she'll be speaking tomorrow. So welcome, Kristen. Another gentleman who's a pharmacist manager with the prescription monitoring program. And that's all I have for now. So one comment, obviously, you were fantastic, Nathan. Other questions coming in. And Christine, just in going with that more integrated approach, I'm not seeing some chat questions, but can you open the mics at this point and we'll see how that works?
Sorry, yes, I'll open the mic to Brittany. She has a question.
Go ahead.
Oh, can you hear me?
Yes.
Yes.
Okay. Yes, I was just wondering if both of the medications that you just discussed are safe for pregnant women, and if there are any other medications that you'd recommend for the opiate withdrawal for pregnant women.
Excellent question. It's a very pertinent question, too, because, of course, we're dealing more so with young folks than with the postmenopausal crowd, shall we say. Sorry, I'm getting a bit of a echo here, but I hope you guys can hear me clearly. In patients who are opiate dependent, it has been determined that it is withdrawal that actually puts the pregnancy at greater issue than do the opiates themselves. Opiate withdrawal in the early stages of pregnancy can increase the risk of miscarriage. In the later stages of pregnancy, opiate withdrawal can increase the risk of premature labor and late miscarriages. The opiates themselves seem to have less of an effect on the safety of the pregnancy. We generally don't see things like, intrauterine growth retardation. There are no teratogenic effects of opiates such that we don't see fetal malformations and so on. In later life, there have not been any clear associations between maternal opiate use and behavioral or learning disorders in their children. So in a patient who is opiate dependent, it would be nice to snap our fingers and make them non-opiate dependent once we've learned they're pregnant. Obviously that is not a reality. So the reality is that we wish that a woman who is opiate dependent goes on a medicine like methadone. Methadone right now is the drug of choice for opiate dependent pregnant ladies. The reason for that is because methadone is a long-acting drug, the patient, when they're at the proper dose, should be able to go 24 hours without going into withdrawal. She should also be able to go 24 hours without becoming intoxicated or without impairing her ability to proper care for herself. So the methadone should be given in place of prescribed or illicit, OxyContin, et cetera, et cetera. We don't want the patient to be using a short-acting opiate because patients using short-acting opiates who are opiate dependent are spending much of their day either having more than enough opiate or having inadequate opiate and going into withdrawal. So methadone is considered safe in pregnancy, and I'll talk about neonatal abstinence syndrome in a moment. Buprenorphine is considered safe in pregnancy, but the naloxone, although not available to the person when taken sublingually, the naloxone is considered an issue in pregnancy. So pregnant women who don't qualify for one reason or another for methadone can be considered to be placed on buprenorphine alone, which is not Suboxone, but Subutex. Now, Subutex is not available in Canada. The only exception is that it could be brought in for special considerations such as this. But that is quite an issue. So quite honestly, we would recommend methadone for patients who are opiate dependent and pregnant. A word about neonatal abstinence syndrome. So babies born to mothers using opiates throughout the pregnancy may well be born dependent upon opiates. And this is the same for whether they were on methadone or illicit or short-acting opiates. If the baby is in fact born in neonatal abstinence, they will require longer hospitalization. They'll be given morphine drops in a gradually tapering dose, allowing them to wean gradually off of opiates, because an opiate withdrawing baby generally does not suck very well, does not thrive. The interesting thing about methadone and pregnancy is that methadone at high dose does not guarantee neonatal abstinence, and methadone at low dose does not guarantee no neonatal abstinence. So we do understand the higher is the methadone dose, the greater is the risk, but it seems to be hit and miss, and that I've had patients on high dose methadone where there's been no neonatal abstinence whatsoever, and I'd have other ladies on very low dose where there's been quite substantial or significant neonatal abstinence. So the long-winded answer you've heard, the short-winded answer to your question is that methadone right now is the drug of choice in opiate-dependent pregnant ladies.
Thank you. Leanne has a question.
Sure.
Go ahead, Leanne. Leanne Paisley, you have a question? She's got no microphone. Okay, sorry, Leanne.
Okay.
She asks, out of curiosity, why not use Subutex over methadone in pregnancy?
Oh, it can. Subutex can be used in place of methadone. It's just not available in Canada. I had one patient who required Subutex. I had to essentially write numerous letters and speak with folks at the company that manufactures it so they could bring it in from the States especially. So it's not that it would be a poor choice. It's just it's not a very convenient choice for patients or for the healthcare workers. And personally, the evidence in methadone pregnancy is quite substantial, and as I said, has been around for decades. The evidence for the buprenorphine in pregnancy is less robust, so I prefer the methadone.
All right, thank you. I believe that there's a question from Michael. Christine, are you able to unmute Michael to ask this question?
It's written here, so I mean I might be able to just...
Okay.
Go.
Yeah,
Go ahead. That's great, Doctor.
Yeah, the question is methadone maintenance or Suboxone prescribing improving amongst First Nations people in the North? Is there much resistance from First Nations leaders to opiate agonist therapy? And this is actually a vital question in Ontario, and I'm a good person to be asked that question because I do see patients in First Nations communities. There are huge problems within people in First Nations reserves in that addictions are rampant. Depending on the native reserve, we might be seeing anywhere up to 75–80% of the populace of a given reserve addicted to largely opiates. The availability is quite high, and the health care afforded to them is minimal at best. There are many reserves where there isn't a single physician, let alone a physician schooled in addictions. So the prescribing of methadone and Suboxone is improving vastly for First Nations communities up north, largely because of telehealth, so Ontario Telehealth Network. Our group has clinics in multiple reserves, in Fort Frances, in Collins Bay, and Sioux Lookout, and places I've never even heard of, honestly, before now. And slowly but surely, patients who had absolutely no access before are getting access. The First Nations leaders actually are not resistant to treatment. If anything, a lot of the clinics that were set up on reserves were set up in response to pleas from the elders and leaders of the communities, acknowledging the problem and saying, listen, we need help. We can't do this on our own. So I find the First Nations communities are very receptive. An interesting sidebar to the First Nations is that because the drugs are so much more expensive in these communities, again, just based on supply and demand, the rate of use of addicted individuals is a lot lower. People in First Nations communities, the average dose, shall we say, of OxyContin, for example, that they will abuse is much lower than the average dose we'll see someone in Toronto, for example. So as a result, these are folks who do better in treatment in that we'll get them to a stable methadone or Suboxone dose quicker, and also owing to the fact that their brain pathways have not been, again, for lack of a better word, perverted to the degree that many of the people in the populated areas would have. So the simple answer to Michael's questions is that the methadone and Suboxone prescribing is much improved in the First Nations. Certainly over the last 10 years, I mean, I wouldn't be surprised if there's been a 100-fold increase in the number of patients in treatment who need treatment. And I don't have numbers to back that up. I'm just going from personal experience. And I will say that the elders in general, the leaders of the First Nations communities, are very receptive to our interventions.
Thanks, Dr. Frank. Are you able to see the other questions in the chat, or would you like me to read them?
Well, actually, I'm looking back. I think there was one before Michael's, and that was how do people find their way into opiate agonist therapy, and how do we increase access to those who need it? Patients self-refer. A patient needs to present themselves to, I mean, with our clinics, you come in and say, hello, I'm interested in getting some questions answered. Patients do not require a formal referral. And in fact, we obviously need the patient themselves to initiate the first steps to treatment. You know, concerned loved ones, family members, even concerned healthcare workers, if they make the referral for the patient is not willing to take that step, if they are in the pre-contemplation or contemplation stages of their recovery, we know that the chance for success is ridiculously slim. So the patient has to be in the action phase. They have to be ready to take that step toward recovery, and one of those steps involves literally walking into one of our clinics and saying, you know, where's the paperwork, how do I get this thing started? Increasing access would involve getting more physicians interested, which isn't the easiest thing in the world because the myth and the biases against patients in addictions carries through oftentimes to the physicians working in addictions. It's also an interesting area of practice in that the government scrutiny of doctors in treatment programs is high, and if a physician does not want a big brother, shall we say, looking over their shoulders, they will not enjoy working in addiction. So those are some of the barriers to getting more people into treatment, is getting more physicians and nurse practitioners and so on into treatment. We as a group, Ontario Addiction Treatment Centres, are opening in clinics in new communities all the time in response to a stated need. So, and I know there are other groups as well who have clinics in multiple communities in Ontario. So, I mean, the access is increasing, but still, I mean, the single biggest barrier is just the patient either not willing to take that step or not understanding what's involved in taking that step.
Mm-hmm.
Okay. And I see there's one more question, actually, Kim. It's the only other question I see. How do we address stigma and myths, and how do we, who do we need to inform and influence? And as I said, this is the unfortunate thing, the truism of any of these educational talks, any kind of continuing medical education, is that generally the people who are most in need of listening to what we have to say are the ones who are least likely to even open their ears or attend. Physicians are guilty of this as well. physicians, when choosing the required, all physicians are required to undergo continuing medical education. They have a certain number of study hours that are required each year in order to keep their certification. Physicians are well known to attend talks in the area in which they are most comfortable, not the area in which they're least comfortable. And I would imagine that's the same for people across society, where if it's something that's just a very scary black box, you tend to avoid it. So everybody attending a session such as this is certainly, any positives that you take from your experience in dealing with people with addictions, to sort of spread to the community, to dispel some of the myths that we discussed here. And again, I understand these materials will be available for folks after the fact. So if you want to go back and refresh yourselves in terms of, how do I respond to the people who say this, that, and the other about addiction treatment programs, there is information for you.
Mm-hmm.
Okay. Everything's gone silent on my end. Is there anything else that needs to be said, Kim, or are we about to say goodbye to our guests?
Sorry, this is Christine. I'm not seeing any more questions.
Okay.
Hi, Nathan. Can you hear me?
Yes. Yes.
Hi, I don't know what happened to Kim, but everybody, this is Michael from Waterloo Region, and I think we'll wrap up here. Great point about the people who are most likely to attend an event, or possibly the people least likely in need of attending. I would encourage those on the line and others to share the Eyes Wide Open webinar series. They're being recorded, and part of the hope here is that it's a safe way for people to sort of enter the tent and learn more about these kinds of issues. So the other thing I want to mention, it sounds like shameless self-promotion, but it's not. The Crime Prevention Council has just released a film called Eyes Wide Open. It's on the website. It's about 7 minutes long. It's more about overdoses and naloxone, but featuring two Canadians. It's a hot film so far. We hope that's another safe way to draw people into the tent, into the discussion, because certainly we know the fatality rate is extremely high, and compared to the U.S., Canada really shows an absence of leadership and an absence of coordinated efforts. So I think there are no adults in charge. Nathan, I thank you very much again. I could listen to you for much, much longer. You've got the radio voice, and you've got the knowledge that is always impressive. And I thank you for all of the work that you've done, and participants on this line, I thank you for attending. And again, I hope that you'll share it with your friends, networks, and colleagues near and far. On behalf of all of us at the Crime Prevention Council, thank you so much. We'll be back again tomorrow with two sessions. The first in the mornings from a local group delivering practical overdose information. And in the afternoon, we're quite honored to have Kristen from Scotland. Scotland has a national overdose prevention via naloxone program that is in place in many communities. It's often peer-driven. It happens to exiting prisoners, et cetera, et cetera. So please join us tomorrow. And if you can't, by all means, tune in later. Thank you so much, Nathan. Very much appreciate your time.